Medical Reasoning with O3 Mini. Hi, everyone. My name is Yudhara. I'm a consultant physician and CEO of digital diagnostics startup called eHealth. I got a good response for the video I did about R1 DeepSeek medical reasoning. And believe me, AI models are growing very fast, especially in the medical field. The reasoning is becoming very important and it's showing some really, really good results. And as you know, O3 Mini is out. And then I thought I'll compare one of the cases, which I did with R1, exactly same with O3 Mini and see how they stack it up together and perform. Okay, let's start. For the people who have not seen my first video, all the personal identifiers has been removed and some of the minor details have been modified to prevent the case being identified. And this gentleman, it's a 41-year-old male, Chinese, seen in Singapore, came with severe chest pain. This gentleman is previously very fit actually, was doing karate session. He regularly exercised. During the karate session, he suddenly got a severe pain on the chest pain. And it was so severe, he said almost close to the most severe pain he have ever experienced. It went up to the neck, it went up to the leg. So he sit down, didn't fall down, and after some time, the pain slowly get better. Colleagues called the ambulance, and he came to emergency department. And we were worried about acute coronary syndrome. There was no other things like fever, cough. He was eating, drinking well. There was no recent trauma. Vitals were more or less okay. Heart rate is slightly tachy. Blood pressure was normal. Respiratory rate slightly high. Examination wise, relatively okay. Nothing fancy. ECG was done, and there was no obvious ACS, acute coronary syndrome, STEMI features like ST changes. We did some bloods, full blood count, and renal panel again completely normal. Troponin slightly on the baseline high, just at the cutoff, and we did a chest X-ray, which is also normal. This case initially looks very serious, but after that it looks maybe nothing serious because pain got better. His bloods and vitals and ECG looks okay, and surprise, surprise. With the R1 reasoning, O3 started showing the reasoning in much, much more detail. Last time in O1, they only give like thought for how many seconds and that's it. But now it starts showing, and then I can see that human nature. I'm analyzing Jones. So that is clearly to me, I have first noticed in R1 DeepSeek, and then now it's very obvious in O3 Mini also. And Sam talk about it. So O3 starts very nicely analyzing the basic scenario and taking a closer look at all the important things, and then thinking about the differential diagnosis. So he immediately come to think about aortic dissection and ACS, and then evaluating all the other possible. This is beautiful. Again, as I mentioned in R1, thinking through a list of possibilities. Is it heart? Is it esophagus? Is it lungs? Is it muscle? Or is it psychological? So it weighs good and bad. And then focusing on aortic dissection, which sounds like it from the history, but vitals and blood tests not really supporting it. So it comes to it, and then it says, yeah, I'm looking at dissection differentials, but considering heart sensation and changes in vital spin point, maybe not. Doesn't sounds like typical. And then he noted that musculoskeletal pain usually doesn't describe as theory, but it's also possible. And then it comes to the evaluating. Actually, this is something interesting. It comes back again for the second time, and then looking at this aortic dissection, musculoskeletal, and chest pain as an important part. And then wondering about aortic dissection. Then he focused on it and said, considering other possibilities. So not seeing elevated blood pressure or trauma. This is very important. A lot of dissection patients come with very high blood pressure, which leads to the tearing, right? So he said, I like it, but the blood pressure is not. So maybe I'll think about something else. So then he come to it, and then he pieced together and then try to summarize it. And then, of course, after that, he said, okay, let me think about all the other critical things. Maybe it's critical, but not in this case, like pulmonary embolism and all the other things. He looked at it and then said, okay, let me piece this, and then start analyzing the data again, spotting the potential causes, and then piecing together again. You can see it back and forth, going few cycles of differential diagnosis and reanalyzing it, and then weighing the next steps. Of course, I have to CT iodogram and repeating ECGs, and then next steps, evaluating potential causes again. Just before he released the data, he think, okay, let me think again one more last time and then put it in out. And I like O3 how it presents the data, which is compared to last time much smarter. He gets the clinical data summarized, the patient data, so that it's clear, and then comes to the differential diagnosis. He said, always rule out first, which is very clear. I said, I'll think about the life-threatening conditions. As an ER doctor, I like this way very clearly. So he said, look about ACS, and then he said, look, this is what I think, and this is what I don't think. ACS is not really tearing, and then supporting is troponin slightly elevated. Maybe it'll elevate it in the next one, and then do a serial ECG and troponin, which is what we do in ER. And dissection wise, he think that tearing sounds like dissection, but conflicting patient's blood pressure is not high. So, which is for us, my junior doctors also like, yeah, the blood pressure is normal, so I don't think it's dissection. And then, of course, beautifully look into other things like muscular skeleton. And he said, look, he was doing karate, so maybe it's like muscle tear. But also, say, tearing is not typically musculoskeleton per se. But of course, if you really tear muscle fiber, then you might feel that way. And then he put these things, and then he come up with the priorities: ACS and dissection. Do these things so that I can verify whether it's. And then he gives very clear next steps. This is honestly amazing. But the last one, in this case, in reality, it was aortic dissection. We did a bedside ultrasound, which shows false lumen, which we immediately go for a CT aortogram, which shows a dissecting aorta from all the way from the aortic root to the femoral to carotid arteries, which is a very serious, had to undergo repair immediately in OR. So, but this gets the basics very correct. But if you compare to the R1 still put dissection as the first possible. This one said, look, I would exclude these things, ACS and dissection, but I think it's muscular skeleton. So at the end of the day, I think R1 still did slightly better. Cannot wait for O1 full to see how they evaluate these things. But at the end of the day, one thing for sure, this is beautiful medical reasoning, way better than a junior resident and almost at a consultant level. And my big question is, when you have such amazing models, if you're not using it, I almost feel like it's becoming a medical negligence or unethical not to give the best treatment to the patient. Because most of my relatively junior doctors might not good as this. And data analysis part should be done with AI already. Thank you so much, guys. I'll try to do a comparison with R1 and O3 Mini in medical reasoning again. Bye.